Hello and welcome to today's webinar. My name is Trevor. I'm the Communications Manager for the Canadian Cancer Survivor Network. Thank you to everyone for attending today's webinar, which is the latest in the fall leg of our 2025 webinar series. If you are new to our webinar, a little background on our group. CCSN works to connect patients, survivors, and other stakeholder groups with decision makers and the wider community to engage in evidence-based best practices and to alleviate the medical, emotional, financial, and social costs of cancer. To learn more, visit survivornet.ca. This webinar is being recorded and will be available on YouTube, and a link will be provided by the email you registered with, along with a link to the slides provided with this presentation. We'll have a quick Q&A session at the end, but if you would like, please put your questions in the chat and the questions tab at the GoToWebinar function. This webinar was made possible by grants from AstraZeneca, Eisai, and Merck, AbbVie, Amgen, Bristol Myers Squibb, and Janssen. It's because of their continued support that we can host the CCSN webinar series, and thank them for their commitment to our educational endeavors. I'd like to introduce our speaker for today. Eric Antonen is a first-year PhD student with the Institute of Medical Science at the University of Toronto and the Princess Margaret Cancer Centre, as well as a registered kinesiologist with the ELLICSR Health, Wellness and Cancer Survivorship Centre at PM and the Toronto Rehabilitation Institute, Rumsey Centre for Cardiac Rehabilitation. He holds a bachelor's degree in kinesiology and a master's degree in medical science from UT. For his MSc thesis, he conducted a pilot study of an innovative, remotely delivered exercise-based rehabilitation program called EX-CIPN for cancer survivors with persistent chemotherapy-induced peripheral neuropathy. His doctoral thesis has continued focus on the symptomatic treatment of CIPN using exercise-based rehabilitation. And so without further ado, I'd like to hand it over to Eric for his talk, Chemotherapy-Induced Peripheral Neuropathy.
All right. Thanks so much for the introduction. Thank you to everybody who came. My name's Eric. As was mentioned, I'm a PhD student at Princess Margaret and the University of Toronto. My research focuses on exercise-based rehab for chemotherapy-induced peripheral neuropathy. And today I'll be talking about a few of the other treatment options that are being researched, as well as a look into the exercise-based rehab program that we created over at Princess Margaret. So just to start with a little background here, as we know, chemotherapy is a necessary component to cure many common cancers. However, it can induce changes to cell structure and function, resulting in some toxic effects. Chemotherapy-induced peripheral neuropathy, or CIPN, is a prevalent adverse effect of many adjuvant or curative chemotherapy agents and can develop at any time during chemotherapy receipts or occasionally after treatment completion. It's estimated to be present in about 2/3 of patients who receive neurotoxic chemotherapy, and it generally improves over the first 3 to 6 months following treatment completion. However, in about 30 to 40% of patients, CIPN signs and symptoms, such as neuropathic pain or decreased sensation, can persist for months or years post-treatment. This number is even higher in patients treated with taxane and platinum-based chemotherapies. So just to reiterate on that last point I had, there are two major types of CIPN when we look at CIPN. Firstly, acute CIPN, which is the more common and is present in about 60% of people who experience CIPN symptoms. It generally subsides within 3 to 6 months of finishing chemotherapy treatment and can improve on its own with no formal extra treatment or intervention, but it can also be benefited by the use of an intervention. And then persistent CIPN, on the other hand, is present in about 40% of patients and generally starts when a patient is greater than 6 months post-chemo and still experiencing those CIPN symptoms. This form of CIPN is more chronic and can last for multiple years post-treatment. And although it may have a positive or negative fluctuation in symptoms over time, it may require treatment intervention to try to improve the symptoms over time. So, although there is no exact pathophysiology or mechanism for CIPN known currently, there are a few hypotheses on the mechanisms of chemotherapy that could potentially lead to neuropathy. Firstly, chemotherapeutic agents have been found to bind to mitochondrial DNA in both cancer cells as well as healthy nerve cells. So by binding to this DNA, these agents impair the replication and transcription of the DNA and cause impaired physiological function of the mitochondria within the nerve cells. And this impaired function can then lead to decreased cellular metabolism, increased oxidative stress, and ultimately leading to neuropathy symptoms. This is the most common expected mechanism with platinum-based chemotherapies such as oxaliplatin and cisplatin. Another mechanism that we see of CIPN is microtubule disruption. So microtubules are an important part of the nerve cell for transporting your lipids, proteins, and ion channels within the cell. They also help to maintain the cell's shape and stability. Chemotherapy, most commonly taxane chemotherapies in this case, such as paclitaxel and docetaxel, can cause microtubule disruption, leading to axon degeneration or breaking down of the nerve endings that can lead to motor issues and sensory abnormalities. And this usually starts in the distal nerves, so the fingertips and toes, and then works its way up. And then finally, another mechanism that we see leading to the development of CIPN is the activation of inflammatory mediators. So chemotherapeutic agents can directly affect the function of glial cells, which are cells tasked with supporting neurons and maintaining their environment. These agents can cause glial cells to release and elevate the presence of pro-inflammatory cytokines. So this increased presence of these cytokines can activate the nociceptors in the peripheral nervous system, which are in charge of initiating the sensation of pain. So this can bring up pain or symptoms without anything causing them. And this can develop from both platinum and or taxane chemotherapies. Other chemotherapeutic drugs, other than the common taxane and platinum-based drugs, can also potentially cause CIPN, the first of which is vinca alkaloids, the most common being vincristine. Vinca alkaloids can work in a similar way to taxanes by disrupting those microtubules, which we just discussed. And then bortezomib and thalidomide can also lead to CIPN. However, their mechanisms of action are currently still unclear. As CIPN is considered a predominantly sensory neuropathy, sensory symptoms of CIPN can present as positive or negative symptoms. So positive sensory symptoms include paresthesia, which presents as a tingling, burning, or pins and needles feeling in the hands and the feet, but can also be a combination of all of them. Temperature sensitivity can also arise most commonly to colder temperatures. And then negative symptoms include things like numbness, loss of joint position, and difficulties differentiating between hot and cold temperatures. Motor symptoms can also arise, such as muscle weakness and atrophy, and these symptoms can then lead to functional impairments within CIPN patients, having around 3 times higher falls risk than other cancer survivors without CIPN. These patients can also experience gait disturbance and overall physical deconditioning. So for the prevention of CIPN, there are currently no recommendations on the use of any pharmacological treatments to prevent CIPN, and non-pharmacological interventions are being tested for prevention. These include nutritional interventions such as supplementation of calcium, magnesium, vitamin B, and vitamin E, and also cryotherapy and compression therapy. However, due to a lack of evidence or negative results on current studies, none of these have been recommended in guidelines as an intervention to offer for prevention. Recent guidelines have, however, stated that the use of frozen socks and gloves for cryotherapy and the use of surgical gloves for compression therapy can be considered for use clinically, but no official recommendation can be made yet due to the lack of evidence. Currently, there are no evidence-based approaches, again, for the prevention of CIPN, and the symptomatic treatment options for established CIPN, including pharmacological treatments, are limited, and the benefit is uncertain as of yet. Pharmacological agents that are effective for the symptomatic treatment of other neuropathies, such as diabetic and HIV-related neuropathies, including tricyclic antidepressants and anti-epileptic drugs, require more caution when used for adults with cancer and have shown negative results currently with CIPN. Duloxetine, which is currently the only recommended pharmacological agent for the symptomatic treatment of CIPN, and is also often prescribed to patients with CIPN, has also shown some limited benefits, but it hasn't yet been compared against all types of cancer or chemotherapy. Other neurological agents like gabapentin and pregabalin, which are also commonly prescribed in CIPN, have been tested to prevent or treat CIPN in clinical trials, but the results have not yet supported their use. The opioid tapentadol was tested in one recent study in a CIPN population. The drug showed significant reduction in pain intensity in CIPN symptoms. However, 85% of participants reported at least one adverse event, including nausea, vomiting, insomnia, and also patients can develop dependence if it is taken regularly. So no recommendations have been made there yet either. And then the most common topical treatments, capsaicin cream being the most common, has not yet been tested in CIPN. However, it has shown promising effects in other peripheral neuropathies and is commonly prescribed clinically for CIPN. Ketamine amitriptyline creams have also been tested in CIPN, but showed no effects on symptoms yet. So due to the lack of these pharmacological treatments available for CIPN, testing started on non-pharmacological treatments. The first of which being acupuncture, which has shown some promising effects in reducing CIPN symptoms, with electroacupuncture being the most effective type. However, there are a limited number of studies available, which is becoming a common theme here. So no recommendations have been made yet. There are also many barriers, including the cost, training needed, and a general dislike or fear of needles, which can stand in the way as well. Scrambler therapy, which is a new innovative technique that delivers electrical stimulation to the pain fibers, which can be seen in the picture there on the bottom right, has shown mixed results in treating CIPN symptoms, and this treatment also unfortunately presents a cost barrier for clinics as well. And finally, the TENS machine has also been tested in populations containing patients with CIPN. However, they haven't been tested in CIPN alone. And these studies have reported no significant improvements in pain scores and intensity, and also the lack of research, which again, you may notice is becoming a bit of a trend with these treatments, has led to, again, no official recommendation for this treatment yet. But again, this is one that is used clinically currently for CIPN in some clinics. Now moving on to exercise. So exercise-based rehabilitative interventions have been shown in the past to be effective for managing many common side effects of treatments and enhancing functional abilities in individuals affected by cancer, both during and after treatment. Recent evidence has also shown that exercise is feasible and may be an effective intervention for different forms of peripheral neuropathy and for patients experiencing CIPN specifically. So in order to alleviate the symptoms of CIPN, exercise may work through several neurophysiological mechanisms, such as the induction of an anti-inflammatory environment, increasing the supply of blood, glucose, and oxygen to mitochondria, and by affecting psychosocial processes. So you may notice that some of those relate back to the mechanisms that can potentially lead to CIPN. And while the evidence on exercise-based rehab is currently modest and varied in terms of the interventions tested, there are still encouraging positive effects on CIPN symptoms currently. So just a specific example here, this is a recent study that was done using an at-home 10-week muscle strengthening and balance exercise program for cancer patients who were currently receiving chemotherapy and were found to have CIPN. And as seen in the graph here on the top, after completing the exercise intervention, patients improved their neuropathic pain significantly when compared to a control group. And similarly, as seen in the graph on the bottom, symptom experience as well as neuropathy life interference also improved significantly when compared to a control. So these findings presented the potential effectiveness of exercise in reducing the CIPN symptom burden. However, this study was done in a population of patients actively receiving treatment and didn't have a long-term follow-up. So we have no knowledge on how that would have continued post-treatment. But despite the preliminary evidence coming out currently with exercise, no strong recommendations have been made by any professional organizations regarding the use of exercise-based interventions in CIPN symptom treatment. There are, however, some clinical recommendations for general exercise in CIPN. As seen in this chart here, the recommendations touch on many different forms of exercise, including balance, cardiovascular, and resistance training. And on top of this, they also give recommended durations of activity and frequency. Whole body vibration training was also added here, as there are a lot of studies coming out on that. And there is some promising research around it as well. But to expand on these basic recommendations, most research trials of exercise programs in CIPN provide outlines of the programs that they used and usually give ideas for more neuropathy-specific exercises. So for example, in this program here, there are many hand and foot, wrist, and ankle-specific exercises, with most exercises focusing on the limbs. So just to reiterate, the current literature on exercise, although promising, is held back by low study quality currently, no use of behavior change theory, even though it's recommended in exercise interventions to promote their success. And in their literature, there's also a lack of focus on that persistent CIPN group, which is that form of CIPN, again, that lasts more than 6 months. And can become more chronic, and also a lack of virtual exercise-based interventions, which tend to be a preference among cancer survivors. So to address these gaps, using the exercise recommendations as well as those CIPN-specific exercises from research, we developed a 10-week exercise-based program for cancer survivors with persistent CIPN, incorporating that virtual delivery, behavior change, and neuropathy-specific exercises. So the intervention itself is a 10-week virtual program delivered by a registered kinesiologist, made firstly of an individualized exercise program, which includes resistance, aerobic, and flexibility exercises, with exercise throughout targeting CIPN symptoms specifically. The program is also supported by an app called PhysiTrack, which allows participants to view their exercises with demonstrations from home. And it also contains remote monitoring through a Fitbit device to monitor the participants' physical activity and promote behavior change through self-monitoring. And also, participants have access to 5 remote clinical support calls with a kinesiologist to review and progress the participants' exercise program as needed, and also to discuss and develop goals, identify any potential barriers to the program. So the neuropathy-specific exercises that we used were built in throughout the program in the resistance section and in the flexibility section using desensitization and nerve gliding exercises. So to start off with the resistance exercises, resistance exercises for neuropathy can improve blood flow to affected areas, reduce inflammation, and help to rebuild mitochondria. So again, just reiterating those mechanisms that we discussed earlier, this can help with CIPN, as inflammation can arise from many different types of chemo in the nerve cells. And the potential key mechanism of platinum-based chemotherapies is its ability to bind to that mitochondrial DNA, decreasing mitochondrial levels. So this is where the blood flow to affected areas can help to rebuild these mitochondria and restore nerve function. So some of the upper body exercises we used included forearm flexion and extension exercises, like the one shown here with the stick in the top picture. Also, the gripping of different strengths of balls, from a stress ball to a tennis ball to a lacrosse ball, can help to activate the fine motor skills in the hands and also the forearm muscles as well. And then for the lower body, we used toe flexion exercises, which were trained by grabbing a towel with the toes, as seen in the image on the bottom. And we also used calf raises. And then also the major muscle group exercises like a chest press or a back row were still used in upper and lower body to help promote that blood flow and also build overall strength. For desensitization, desensitization exercises can be used to introduce new stimulus that may be painful or cause increased symptoms at first, but by introducing it frequently, the nerves can become more familiar with these textures and decrease pain or symptom feedback. So all of our participants were provided with a textured ball, as you can see in the top image. Depending on symptom areas, we provided them with a pressing and rolling exercise for either the heel, arch, and or ball of the foot. Other textures were also introduced for some patients, including rice, cotton balls, rough mats, or towels. The most common was submerging the hands or feet in rice and squeezing and releasing with the fingers or toes. And then finally, temperature training was also introduced in patients where we would expose their hands or feet to cold water or ice and quickly move to warm water or a heating pack to help with the differentiation between temperatures. And then finally, we had the nerve gliding or flossing exercises, which can allow for increased nerve mobility and function by improving the nerve's ability to glide through surrounding tissues. So again, with inflammation being a common issue with CIPN in the nerve cells, this can cause some tension on the surrounding tissues, making it harder for the nerve to move. So these exercises can help to combat that. So in the upper body, patients were introduced to ulnar, radial, and or median nerve glides, depending on the symptom areas. The ulnar nerve glide is shown here on the top picture. And then on the bottom, for the lower body, we use sciatic nerve gliding, which you can see, again, that picture there on the bottom. So for my master's thesis, myself along with my lab at Princess Margaret completed a pilot study on this exercise program. So I'll talk a bit about the study, some of the results we found, and some of the feedback that we had from our participants. So I'll just start with the objectives. Because this was a pilot study, the main primary objective was to determine if EX-CIPN is feasible, acceptable, and safe in post-treatment cancer survivors experiencing persistent CIPN. And then the secondary objective was to obtain estimates of the effects of the program on CIPN symptoms, pain, CIPN-related disability, and physiologic outcomes. So this study was designed as, again, a multi-method pilot study focused on cancer survivors experiencing the persistent CIPN, so anything more than 6 months post-chemo. After recruitment, participants completed the first baseline assessment, which consisted of an in-person physical assessment and questionnaire package. After this assessment, they completed a 10-week intervention and remote check-in calls. And then immediately after completion, they completed another assessment at 10 weeks, or T2, also consisting of that physical assessment and questionnaire package. And then finally, 3 months after T2, at around 22 weeks, participants completed their final assessment, T3. So to measure feasibility, we looked at accrual rate, retention rates, and program adherence. The target we set out for accrual was 4 participants per month. Target for retention was set at greater than or equal to 70% at each time point, so T1, T2, and T3. And then the target for adherence to each program component, that being the check-in calls, aerobic exercise completion, and resistance and flexibility, was also set at greater than or equal to 70%. To evaluate acceptability, we also asked participants to complete a post-study survey to provide feedback on their experience in the study, and we also conducted in-depth semi-structured video interviews. The interviews helped us to gain feedback on the program components, how participants engaged with the program, and in what ways it impacted their lives and their experience with CIPN. For our secondary outcomes, the first being in the form of a questionnaire package, we used the numeric pain rating scale, which can be seen here on the right, which was used to measure participants' pain level at each assessment. We used this EORTC CIPN 20 questionnaire, which measured CIPN symptoms by asking participants to rate different symptoms in the hands and feet. And then the CIPN RODS, which measured participants' CIPN-related disability. That was a list of many common everyday tasks that can be interrupted by CIPN and rating how easy or difficult those are to complete. And then we also did our secondary physiologic outcomes, but in the form of an in-person physical assessment with a kinesiologist. So for the in-person assessments, we used a grip strength dynamometer, which you can see on the top image here, which helped us to measure upper body strength, specifically the gripping and the forearm strength. The sit-to-stand test pictured on the bottom right, which tested our lower body strength. Did the SPPB balance test to measure balance, as balance, again, can be a common issue among CIPN populations. And then we looked at gait speed and 6-minute walk tests to assess functional capacity. So taking a look now at what we found from our study. So just to start with participant demographics, the mean age of our study participants was 60.3, with the majority of the sample reporting as female and white or Caucasian, and the most common cancer diagnoses among the sample being breast cancer at 44%, followed closely by ovarian cancer at 31%. So just to preface these results, these are still interim results. We just finished with our last participants last week, actually. So we will have those updated shortly. But for now, this is the last interim analysis that we did. However, our accrual rates was calculated as 3.6 participants accrued per month, which narrowly missed our target of 4, but we were still able to reach that sample size that we were looking for. We saw very good retention at all time points. So out of 40 participants, 90% completed the baseline assessments. Out of 29 eligible within this analysis, 27 completed T2, being 93%, and then out of 21 who had the chance to complete T3, 91% had completed the assessment. So good retention there, meeting our targets, and then program adherence. So for our check-in calls, 96% of all prescribed check-in calls were completed, again, meeting that target. Aerobic exercise being the lowest completion of or adherence to the program. Again, still reaching our target, but a little bit lower at 77%. And then for the resistance and flexibility prescribed program, 89% of participants completed their resistance and flexibility program. Again, above our target there of 70%. So safety with the study, the safety events directly related to the study can be seen on the right here. No serious adverse events were reported as part of the program, as all events were graded below grade 3. We had 6 adverse events which are directly attributed to the program. However, all were grade 1 or mild. So some of the common feedback that we noticed in terms of adverse events were expected events such as muscle soreness when getting used to some new resistance exercises, and also slight discomfort in the feet from desensitization exercises. So again, when you're introducing a new texture to your hands or your feet, that can cause a temporary increase in symptoms as a result of that new texture being experienced by the hands or the feet. And then with acceptability of the program, we showed high levels of acceptability as well, as 100% of participants stated that the program was either somewhat useful or very useful, and 95% stated that they were either somewhat satisfied or very satisfied with the program. But to get into the feedback from our qualitative interviews, so when analyzing these interviews, we had 4 sort of main themes that arose. Those themes being the benefits experienced by the participants, the facilitators of the program benefits, the identified drawbacks of the program, and the barriers to program participation. So when discussing benefits experienced, the main sub-themes that we found brought up most by participants were the new knowledge and skills they acquired to manage their CIPN symptoms, their experienced improvements in CIPN and overall symptoms, and the support they obtained from the program. And when discussing the facilitators that they had to these benefits, they touched on the access provided to helpful resources such as the Fitbit and the PhysiTrack, the effectiveness of the program design, and the ease of those study requirements, so that being the questionnaires and the assessments. The main drawbacks that we found were discussed or that the program delivery could be improved in terms of the repetitive nature of the exercise program, and that some experienced a lack of symptom improvement based on what they had initially expected. So with persistent neuropathy, symptom improvement can be a slower process. That is something that can take a little bit longer throughout the program, and then after the program to continue to improve. And then finally, the main barriers to participation that were mentioned were transportation difficulties to our in-person assessments, symptom burden, the underutilization of program tools, specifically the Fitbits, and a lack of recruitment at the exact 6-month mark post-treatment. So here are some specific examples of quotes that we found from the interview with a main code that came up kind of under each theme. So the first quote we have here is from a female breast cancer survivor, age 72, who discussed that the program did improve coordination and in many ways balance. So this showed a common discussion point under our theme of benefits being symptom improvement. The second quote from a male colon cancer survivor, age 44, discussed a common code under facilitators, which was the appreciation for the program's remote delivery because he was from out of town. So the virtual nature made it easier to complete. The third quote here from breast cancer survivor, age 49, I'm kind of bored with doing the same thing again and again. So this is what I mentioned with the repetitive nature of the program. And although this can be a motivator for some, others prefer to have variety with their programs, supporting the need of an individualized program design for each participant specifically. And then the final quote from a female breast cancer survivor, age 68, some days my shoulder's hurting, so I don't do certain things. So this discussed, again, the most common barrier of symptom burden, because it's important to note that cancer survivors are experiencing other side effects of treatment outside of CIPN that can hinder them from completing certain exercises. So for the secondary clinical outcomes, the results for our study, this graph shows the effect sizes and confidence intervals for our clinical outcomes from T1 to T2. So this is from the baseline to immediately post-program. So all outcomes that improve as scores increase are above the black line, and outcomes that improve as scores decrease are below the black line. So we saw a large effect on CIPN symptoms through the CIPN-20, which is highlighted here in red, a moderate effect on our CIPN-related disability outcome, and then a small effect on gait speed, sit to stand, and 6-minute walk test is highlighted in green here. And then for our results from the T1 baseline assessments to T3, our final 5.5-month follow-up. This graph again shows the effect sizes and the above the black line outcomes that improve with scores increase, below outcomes that improve with scores decrease. So it's highlighted here in red. All scores that are shown in green on the graph represents outcomes that showed a statistically significant change. So we saw a statistically significant improvement in CIPN symptoms, CIPN-related disability, gait speed, grip strength, 6-minute walk test, and sit to stand. And we also saw a minimally clinically important difference for the CIPN-20 sit to stand, gait speed, and 6-minute walk tests at this point. So some good improvements in our outcomes from the first assessment to the final follow-up. So some clinical observations that we made throughout the study. So firstly, differences were observed in sensory symptom feedback to study exercises, particularly the desensitization exercises, with participants closer to 6 months post-chemo reporting that they experienced expected increases in sensory symptoms that subsided towards the 10-week towards the end of the 10-week intervention. However, participants 2 years or more post-chemo seem to experience a sharper initial increase in symptoms that lasted longer than the 10-week period, but improved towards 3 months. So although these increased sensory symptoms represent a positive improvement in nerve function, they're reflected as negative results on our patient-reported outcome measures. So it may be harder to track progress for this population of patients. We also noticed improved scores to our long-term follow-up. So scores improved on the majority of our outcomes from T1 to T2, and then improved even further to T3. So this goes against some of the previous survivorship research, which normally indicates a plateau or slight decrease in results to the long-term follow-up. And this could simply be due to the fact that neuropathy can take longer to improve as opposed to some of the other outcomes like strength and functional capacity. And then finally, functional improvements were also observed in participants with gait aids. 2 participants arrived at our T1 assessment with gait aids and did not arrive at T2 with the gait aid or use it for any assessment at the T2 time point. And then some learning points on feedback from participants and things that I learned clinically. Firstly, the foot desensitization exercises with the textured ball seem to have the most positive feedback from participants. Depending on the symptoms they had, they reported that it either sort of relieved tension in their feet or helped to give them some sensation on the bottom of the foot in places where they previously had numbness. And most of the participants in the study chose to complete this exercise multiple times a day. I also noticed a commonality between participants that when their job requires the use of fine motor skills in the hands, such as typing or playing an instrument, their neuropathy in the hands is much more improved than the feet after 6 months. And this allowed me some insight on, again, potential exercises to add, such as the squeezing of the balls with different difficulties, so stress balls, tennis balls, to activate those fine motor skills, but also the importance of activating the fine motor skills in the toes, which we don't do quite as much. And then finally, many participants mentioned an increase in symptoms at night that would either keep them awake or wake them up during the nights. And for this reason, they would often do some of these stretches like a calf stretch or forearm stretch, as well as the ball desensitization exercises prior to bed if they found it relaxing. And some would also soak their feet in warm water or use heating packs to try and prevent cold feet at night. And for some, doing these things help them to improve their sleep at night. So based on the feedback and the results, we had some suggested program adaptations for our program that we will look at moving forwards. Firstly, we want to look more into subgroup analyses. After observing differences in that path to symptom improvement for patients who are further removed from chemo, adding an analysis based on time since the end of chemo could give us an idea of differences in symptom improvement throughout the program and follow-up. And also to assess the longer-term impacts of the program and to address participant feedback on the want for more assessments, 6-month follow-up should be added as well. And then to more accurately assess the effects of our program, the primary clinical outcome should be changed from the pain rating scale to the CIPN-20. This is because the CIPN-20 covers more of the common CIPN sensory symptoms, while the numeric pain rating scale only assesses pain. And assessing pain alone can be problematic with CIPN as it is predominantly sensory. So the highest reported symptoms are things like tingling and numbness, while the lowest reported symptoms are neuropathic pain symptoms, such as general pain or burning. So the use of the CIPN-20 helped to provide a more holistic look at the symptoms. Also, to more accurately assess balance, the balance should be changed from SPPB to the modified Berg balance test. This will increase the difficulty of the balance assessment, increasing its sensitivity to changes in balance. The SPPB balance test we originally chose as patients with CIPN have further impaired balance, again, when compared to cancer survivors without CIPN, and this balance test was designed for older adults with balance impairments. However, despite the balance difficulties in the population, there were still very high baseline scores with this test, which led to a bit of a ceiling effect for our study. So we weren't able to look as much into how the program affected balance. So to conclude, our program so far has been found to be feasible, acceptable, and safe, and the study has shown encouraging estimates of the exercise program's effect on symptoms, CIPN-related disability, and our physiologic outcomes. Future studies using a larger sample and randomized design should be done to confirm the effectiveness of this program, as well as other exercise-based programs in the field. And we are currently developing a phase 3 trial to look into this program further. So just to give a quick outline of what that'll look like, we're implementing some of the changes based on the feedback we had from our pilot. So we're going to have a larger sample as well as a control group as a comparator. But participants in the control group will also be offered the program after their T3 assessments. And then for the intervention group, we're incorporating a supported maintenance period between the T2 and T3 assessments. So they'll have an extra 2 monthly coaching calls, and this will also address the participants' want for further follow-up. And the intervention group will have that 6-month follow-up assessment as well to look into those longer-term symptom changes to see if those improvements we saw to our T3 would continue moving forwards as well. And then we will also be looking into the difference in symptom improvements in time since chemotherapy for those less than 18 months post-chemo and more than 18 months post-chemo, again, because of the differences in symptom improvement that we saw. And then we'll also be looking at differences based on chemotherapy type and potentially dose of chemotherapy as well. And then we're changing, again, that clinical outcome from the numeric pain rating scale to the CIPN-20, our balance assessment from the SPPB to the Berg 7-item balance. So that's where our program is going moving forwards. I just wanted to acknowledge and give a shout out to my principal investigators as well as my co-investigators and the team at ELLICSR Cancer Rehab and Survivorship Center for all of the help so far in creating and running this program. Thanks so much.
Wonderful. Thank you so much, Eric, for that presentation. It was very informative. If you have any questions, please put them in the Go to Webinar Questions tab. My question for you is that is the big glaring part of this entire presentation is that there is a very big gap in research on this. And so I was wondering if you could comment further about what the research landscape looks like and what kind of advances, aside of course from your own, the ones that you've been showing, what other advances are there, and could we be seeing more research on the horizon for this condition?
Absolutely, yeah. On the pharmacological side, there's not a lot of research going on because a lot of the current drugs being used are developed for other neuropathies such as diabetic neuropathy and HIV-related neuropathy. So there's kind of uh, an assumption that they will then work for chemotherapy-induced neuropathy, but that's not always the case because between the different neuropathies, there are a lot of differing symptoms. So sometimes those drugs will work for some people, sometimes not. But on the non-pharmacological side, there is some new studies coming out on exercise-based interventions specifically. A lot of them a mix of a resistance and balance and aerobic, so general resistance, balance, aerobic exercises. We tried to incorporate some of the neuropathy-specific exercises that I showed briefly there, which should also help to give some extra insight on what exercises you can do specific to neuropathy. But I'd say most of the current research is coming out in the non-pharmacological side. So things like acupuncture and exercise-based programs or balance-based programs.
Excellent. Tracy asks, has there been any research on vibration plates / machines for CIPN?
Yes, yeah. There's a lot of new research coming out on vibration training, actually. The results currently a little bit mixed. Again, a lot of these studies are introductory, so they don't have a large sample, and they're more of a pilot to the program. So the results will usually be a little more mixed at this point, but they have been included in some recommendations. Exercise recommendations for neuropathy. So it is looking promising there. I haven't tried it with the population myself, but yes, there is some research coming out on that side of things that is showing positive outcomes on neuropathy symptoms.
Mm-hmm. And Warren is asking about the about yoga and how that kind of fits in, because he said it was absent from your presentation. He was wondering if it about the benefits of that for this particular condition.
Sure, yeah, absolutely. I think with yoga, it kind of incorporates a couple of the different forms of exercise that are useful in neuropathy into one. So you're getting some of that balance training and core training that is good for improving the balance with CIPN populations that can become an issue. And also flexibility. Flexibility is massive, especially with the hands, feet, legs, arms, just because, again, with neuropathy, you can get some of that inflammation, which can cause the nerve to be compressed within the surrounding tissues and muscles. So yoga is great as well on the flexibility side of things to relieve some of the tension on the nerve cells from the surrounding muscles. So yeah, not as much research as I would like to see on it currently, but it definitely is something that in theory could be very helpful due to those factors for sure.
In terms of the exercise that you have stated in your presentation, Nadia is asking, are these exercises helpful to those currently still receiving chemo treatments?
Yes, absolutely. Although my study focused on persistent neuropathy. These exercises, even if you're currently receiving treatment or you're in this sort of acute phase of 3 to 6 months, you don't want to wait to see if the symptoms subside. These exercises can absolutely help in the acute side of things, helping the neuropathy symptoms to subside quicker, and also even when going through treatments, just keeping the fingers and toes, hands and feet moving can be big in helping to keep some of those CIPN symptoms as minimized as possible. For sure, there's some preliminary research on that as well. Yeah.
Mm-hmm. Marianne asks, do you factor in pre-existing conditions such as Raynaud's syndrome? Your thoughts?
Yeah, I mean, there are a lot of pre-existing conditions that can complicate things, especially with neuropathy. Anything, the ones we've looked into specifically with this study that can complicate things with neuropathy, specifically being other neuropathies like diabetic neuropathy or carpal tunnel syndromes, things like that. We haven't looked into that syndrome specifically, but yes, neuropathy can kind of with certain underlying conditions act as a sort of add-on to them sometimes. So when you have other conditions that affect the hands and feet and the limbs, neuropathy can sort of add on to that. So if that's the case, that again, the exercise could still be helpful in improving the neuropathy symptoms that may add on to that. So yes, we looked at some patients with carpal tunnel and neuropathy, as well as multiple forms of neuropathy, and it can still yes, work with those populations. Yeah.
Mm-hmm. David asks, has any thought been given to running this program during treatment to see if the incidence of neuropathy might be reduced, prevention rather than cure?
Yes, that's where most of the literature currently lies, on the prevention side of things, and in the acute stages of neuropathy. Again, there are mixed results with that, which is why no recommendations have been made on the prevention side of things yet. Some studies have shown positive outcomes of starting the exercise even prior to starting chemo treatments and then completing it throughout. But again, the results are still mixed, and we chose to look at the persistent side of things because that's a group commonly neglected within the literature currently. But yes, there is the bulk of the current research is on the prevention and acute side of things. So leading up to chemo, throughout the chemotherapy treatments, and within the first 2 to 3 months post chemo. So there are some positive results coming out, but again, the results are still mixed.
Mm-hmm. Elizabeth asking more about the study. How will participants be chosen for phase 3?
Yes. So, of course, with this study, there are some inclusion/exclusion criteria. We are, because we're doing in-person assessments, recruiting from hospitals local to Toronto and the GTA. So Princess Margaret, St. Mike's, Women's College, Mount Sinai, Sunnybrook. But with the study, again, we're focusing on the persistent population. So participants who have had neuropathy symptoms for greater than 6 months post chemo. also not presenting other neuropathies or not having neuropathy prior to chemo, like a diabetic neuropathy or an HIV-related neuropathy. And people who are currently getting into exercise or have lower amounts of exercise at baseline, so less than 90 minutes of aerobic exercise, moderate intensity aerobic exercise at baseline per week. So those are some of the things we look for, but the big ones are that because we're focusing on the persistent population, patients that are greater than 6 months post chemo and were treated with curative intent chemotherapy.
All right. Sheila asked this one, and I apologize if I've mispronounced some of the terms that she used. She says, I had severe oxaliplatin-induced dystonia and neuromyotonia with upper limb and facial spasms on initial dose. 14 years later, I still have mod CINN and have some numbness, tingling, and burning facial sensations, which has flared up lately. Anyone look at more extensive clinical neuropathy?
Yeah, I mean, with the facial neuropathy, especially, that's something that is definitely widely understudied. But yeah, I mean, with the facial neuropathy, there is again some research coming out with tools like I don't know if you've heard of it before. It's called a gua sha. It's for bringing blood flow to the face. It's like a stone that you rub along your face. And essentially, from my understanding of what's coming out currently with that, it's the same idea of increasing blood flow to that area. So the same way that we're exercising our hands and our feet by using those fine motor skills, we want to find a way to as well improve blood flow to the other affected areas, which in this case can be facial neuropathy as well. So there is, preliminary data, but again, not a whole lot out there. I wish there were more. But yeah, that's something that I've heard has been used recently. I hope that answers the question.
Mm-hmm. Hannah asks, is itching considered a symptom of peripheral neuropathy? Suggestions for treatment?
Yes, yes. Itching is a common symptom, usually most commonly on the bottoms of the feet. Again, uh, itching as a symptom is the same sort of idea as a tingling or a burning. You're experiencing a different sensation that is not a reaction to um, an itchy stimulus. So again, I think with that, desensitization type exercises will be your best friend for sure, because we're trying to bring back some of that that regular sensation on the bottoms of the feet. So use it or with the hands wherever you're experiencing it. So different textures like uncooked rice or cotton balls, or if you have those, there are those Adidas slides that have the little spikes on them. Those are commonly useful as well with the patients that I've seen, because then you're kind of exposing yourself to that texture for long periods of the day. So desensitization will definitely be helpful with different um, different symptoms or sensations on the bottom of the feet, like itching.
Jean asks, how could a patient at Princess Margaret get access to services for CIPN?
Yes, so with uh, with our cancer rehab and survivorship program at Princess Margaret's, the referral needs to come first from your oncologist. So if you're presenting with CIPN, that is something that you can bring up with the Cancer Rehab and Survivorship program at Princess Margaret, which you can ask for a referral directly from your oncologist. You'll then be seen for a sort of joint initial assessment with a physiatrist and an occupational therapist, and they will give you some strategies of the more known strategies for neuropathy. And since the study currently isn't running, you wouldn't then be sent along to that. But when the phase 3 study starts up, that may be an avenue as well that you could pursue. But yes, the referrals can come directly from your oncologist to the Cancer Rehab and Survivorship program, which has a clinic directly next to the breast clinic in the Princess Margaret building.
I've got a couple more questions. We're running out of about a couple more questions.
Sure.
Frank asks, I live in Alberta and still doing chemo. He's looking for neuropathy in his feet, and is there something online or something around his area that he could try?
There is a cancer rehab program that's it's a brand new program being developed in Calgary. Again, I don't know where in Alberta you're from, but I can't speak too much on how you get referred to it, but I know that's something that is coming out in Calgary. But online, there's again not a lot out there. There are a couple of resources that I have. I don't know if there's a way that I can share those, Trevor. But is that something that I can
we can
maybe
send
add
we can send the information that you have to us, and then through email, and then we can post it with as part of the resources along with this webinar.
Sure.
Also, Wen
Sure.
is asking, if you're not treated at your affiliate hospital, are you still eligible to register for this exercise program?
Yes, well, with the study specifically, yes, if you are able to come downtown for assessments, downtown Toronto. But with the Cancer Rehab and Survivorship program within Princess Margaret, the general program, you do need a referral from your oncologist for that. But for the study, when it starts, it can be self-referral as long as you can come downtown to the hospital. But again, I don't have a date for you yet on when that'll start. But yes, for the cancer rehab program at Princess Margaret, you do need a referral from an oncologist.
All right, well, that is all the questions we have. Thank you, everyone, for those questions. Very thorough. And if you have any other questions, we can put you in touch with Eric if you have any more questions. But that wraps it up for today. Eric, once again, thank you for this presentation. Lots of fantastic questions and a lot of eye-opening research into this part of chemotherapy. So thank you very much for your presentation. I really appreciate it, and thank you for having us on.
Thank you very much for having me.
Excellent. Now, this webinar was made possible by grants from AbbVie, Amgen, AstraZeneca, Eisai, Bristol Myers Squibb, Janssen, and Merck. It is because of their continued support that we can host the CCSN webinar series, and thank them for their commitment to our educational endeavors. We have 2 more webinars going on this year, and then we're going to wrap up the fall season. You should be seeing information about that coming in the next couple of maybe hours, really. And also, if anyone here registered for the fatigue webinar, that is going to be posted on our website shortly because we had a couple technical issues, but that will be posted as well. If you're not seeing our newsletters or these e-blasts in your inbox, check your spam folder because we do use a third-party email service. Make sure you are subscribed to our newsletter. You can go to our website and find that under the newsletter section. And all our webinars can be found on demand at survivornet.ca/webinar or on CCSN's YouTube channel. And so with that, everyone have a fantastic day, and we will see you on the next one.